I'm Charles Kahi. I'm Associate Professor of Clinical Medicine at the Indiana University School of Medicine and Gastroenterology Section Chief at the Rado Bush VA Medical Center in Indianapolis. I'm presenting the results of our study, High Colonoscopic Prevalence of Proximal Colon Serrated Polyps in Average-Risk Men and Women. As you know, colonoscopy carries a central role in the battle against colorectal cancer. However, recent studies have shown that the magnitude of protection afforded by colonoscopy is less in the proximal colon than it is in the distal colon. Several studies have shown that this is largely due to the operator dependency of colonoscopy, as measured by surrogate measures such as the adenoma detection rate and cecal intubation rate. Recently, studies have pointed to the important and growing role of the serrated neoplasia pathway in colorectal cancer, with up to 35% of colorectal cancers being explained by the serrated neoplasia pathway. Now, serrated polyps can be difficult to detect during colonoscopy because, as shown in this figure, they can be flat, blend easily with the background mucosa, and can be covered by a mucus cap, which sometimes acts as a clue to their presence in the colon. The detection of proximal colon serrated polyps has also been shown to be operator dependent and to correlate with adenoma detection rate. Therefore, any discussion about quality of colonoscopy and magnitude of protection against colorectal cancer has to take into account the growing importance of serrated polyps, particularly those which are located in the proximal colon. And the endoscopist who practices high-quality colonoscopy and who measures their adenoma detection rate also has two practical questions that they face almost on a daily basis. Number one, what is the proportion of patients who would be expected to harbor at least one proximal colon serrated polyp? And number two, what is the actual true prevalence of these lesions in the average risk population undergoing colonoscopy? We attempted to answer both questions with our study and used two databases to arrive at our conclusions. The first is our Indiana University Hospital Screening Colonoscopy database, which has been prospectively updated and maintained over the past decade. And the second is a secondary analysis of an existing database corresponding to our study comparing high-definition white light colonoscopy to high-definition chromocolonoscopy for the detection of adenomas. In the first database, there were 6,681 patients undergoing colonoscopy who met our inclusion criteria, and they were essentially average risk males and females over the age of 50 who were undergoing colonoscopy for the first time. In this cohort of patients, the overall adenoma detection rate was 38%, and the proximal serrated polyp detection rate was 13%. There was a strong correlation between adenoma detection rate and proximal serrated polyp detection rate in both men and women. As shown on these two graphs, there was a strong correlation for men and for women, and extrapolation from these graphs shows that an adenoma detection rate of 25% in men and an adenoma detection rate of 15% in women both corresponded to a proximal serrated polyp detection rate of 4.5%. We performed a similar analysis in our high-definition chromocolonoscopy study and found notably that the proximal serrated polyp detection rate was 20%. Taken together, these two analyses show that the prevalence of proximal serrated polyps is much higher than previously thought, ranging to almost 1 in 5 colonoscopies. Importantly, they also show a strong correlation between adenoma detection rate and proximal serrated polyp detection rate. We suggest a minimum detection rate of 5% for both men and women who are undergoing average risk screening colonoscopy.